So we will start the program. Dear Facebook Pure Urology viewers, good evening one and all. As you know, all know that we are doing surgical technique based presentations every alternate day with the eminent faculty across the world. Today we are doing interestingly a different subject which so far we have not done, the microsurgical techniques that are used in andrology. You know, the andrology what was there 30 years back is no comparison to the present status, because of the major reason that subspecialty has developed and the microscope technology has advanced. These two have made the entire andrology management a different subspecialty. Sometimes we feel that it is not part of urology, it is super specialty, because if you don't develop interest and practice casually, it can never be done. Very few in India, even if we want to refer also, we don't have so many surgeons, but the younger generation are willing to enter into this subspecialty. Already gynecology infertility is a huge subspecialty, and 30% of the gynecologists are practicing infertility. But this is a difficult subject because, like previous days TURP, where we don't have the endovision, here also the surgeon will be seeing through the microscope and he will be operating. It is purely technical skill along with your knowledge. So that technical skill acquiring, having patience is not easy. So we thought with the help of Dr. Mohsin, who is my close junior in Guntur, was in touch with Ranjith Ramaswamy, and when I was going through his CV, I am surprised that we have a great speaker today, and he has dedicated his career, like in India Dr. Rupin Shah has dedicated way after the MCH. He has dedicated his research as well as his clinical practice into the andrology. So let us have brief chat with Ranjith Ramaswamy sir, and then we will introduce officially and over the program. For us, good evening, and for you, good morning, Ranjith Ramaswamy.
Thank you very much for having me.
I'm really happy. I thank once again for being a busy academic practitioner. You accepted for the invitation. Along with me, Dr. Siddhalinga Swami is also there to have some doubts and from the audience, from the chat box. Before going, you are born from which place?
I was born in Chennai. It used to be called Madras.
Madras, very good.
And then I moved after high school. My family moved to the US.
Oh, and you did your medical schooling in US only?
In the US, yes. So in the US, you actually have to do undergraduate first. So that takes about 4 years. And then after 4 years, you have to do another 4 years of medical school. So you take a test called medical college admission test when you are an undergrad. Or your BSc.
USMLE was there. USMLE is mandated.
Oh yeah. No, absolutely. So USMLE is an exam that is required for all local and international graduates. It's not a. When you say that time, I'm not that old, but yeah. So no, USMLE has been around since like 1995. So but it's the same exam that is taken by all local graduates and foreign graduates. But that is taken during your medical school. So after you take the medical college admission test, you get into medical school. And then in the 4 years of medical school, then you take USMLE. And urology is one of the very competitive specialties in the US. It was back then, I applied in 2007. And then now it still remains one of the most competitive specialties. Most competitive specialties are dermatology, radiation oncology, urology, ENT, opto, ortho. Basically mostly surgical subspecialties, and then the ones that offer very good lifestyles like dermatology, radiation oncology are all very good, very competitive as well. So for those, you need to score in the 98th, 99th percentile in the USMLE, just like most other foreign grads trying to get into any other primary care specialty. And then I went to medical school in New Jersey, and then I went to Cornell for residency in New York, where I met and was mentored by Dr. Peter Schlegel. So that's where I got my interest in andrology and infertility, and I did my residency training for 6 years over there. And then after that, I went from there to Baylor College of Medicine in Houston, Texas, where I did 2 extra years of andrology specialty training. So Again, there's very few fellowships in andrology in the US. We now at the University of Miami have a fellowship program, but unfortunately it's restricted to local graduates. So you have to have finished residency either in the United States or in Canada to get into the fellowship. And it's become one of the most competitive fellowship programs just because the amount of research and academic productivity that we have at the University of Miami. Great. So basically, so then from Baylor College of Medicine, when I finished the fellowship, I've come here at the University of Miami and started a program in andrology, and it's now my 7th year.
Yeah, 7th year. Very good. Great. I really appreciate that. Who was your mentor in the initial days to go to medical school? If you remember, who influenced you the most in US in your medical schooling?
So I think during medical school, I was working with a pediatric urologist. His name is Dr. Joseph Barone, and they assigned, when you're in medical college, they assigned some clinicians as mentors. They said, here you go, and then when you're first year, second year, any free food that they give anywhere, you just go everywhere. And then I went to one of the free pizza parties. It just happened to be a pediatric urologist. And then I absolutely fell in love with urology. Urology was awesome. It was quick surgeries, quality of life. And then that basically took me to andrology from there.
What about your urology career after entering into andrology? Who made you into that and then told you about the research importance and then making so many papers? My God, so many papers, and especially the last paper regarding corona. This is actually from bottom of heart. Somebody and your own hard work both might have done it. In the urology, andrology, whom you consider good in, and then you wanted to be like in their footsteps, or you learned something best from them, seniors?
No, absolutely. I mean, I have to give a lot of credit to mentors, right? I mean, so I think when I was at Cornell, Dr. Peter Schlegel was probably very instrumental in shaping, in teaching me how to write a paper, how to submit a paper, how to critically analyze the data, how to critically analyze the literature. What is a good paper? What is a bad paper? How do you write a good paper? How do you not write a bad paper? And then Mark Goldstein was at Cornell, and he basically taught how important surgical finesse is. And I think that is extremely, extremely important. Philip Lee was there, and he taught all microsurgery. It's not, everybody cannot just start doing microsurgery. Just because you're good in laparoscopic surgery and the urology, you can't sit under a microscope and start throwing 9 or 10 sutures. You need that surgical finesse. And then when I went to Baylor, both Larry Lipschultz, Dory Lamb were there, and they taught me research, and they taught me how to, do clinical trials and learn how to do basic science research. And then so I learned, I think, a little bit from everybody. And then when I came here, I was able to establish that program. I truly wanted to do something different. And I think the COVID vaccine fertility study in JAMA is probably one of the most important and hopefully public health driven studies that we've done so far.
So how often you come to India? Last question before I introduce
So we used to come every year pre-COVID. I've known Rupin Shah since 2012. So when I was, I think, a resident or a fellow, I came and taught at the Nadiad course with him in 2012. And then ever since then, we've stayed in touch. And I don't remember the number of times that we've shared a stage and given a talk. And I think he's been wonderful. In fact, some of the difficult cases that I have, I go to him because he's seen it all. I think he's seen it all, but I definitely ask him for very difficult cases, and he's always a wisdom of knowledge.
India is a huge country now, 3,000 urologists, and you should influence the younger generation. You are very young, so you should make like what Dr. Rupin Shah has made in India. Now you are next generation, that much papers I am seeing you only. Really appreciated. With this, I will introduce you officially, Swami. With your permission, I will introduce him. After that, you also take part in the discussion. So today, the speaker is Dr. Ranjith Ramaswamy. We are focusing on andrology surgical techniques, predominantly on microsurgical techniques. And briefly, Dr. Ranjith Ramaswamy, as he said, is born in Chennai and then so-called Madras, and then he moved to, along with parents, to USA. He's associate professor at University of Miami. We all Indians should be proud of him. He is a Miami-based medical researcher and urologist. He currently serves as director of the Reproductive Urology Fellowship Program at the University of Miami Miller School of Medicine. He is known for academic contributions to reproductive medicine, including testosterone deficiency, regenerative therapy, erectile dysfunction, and prostate cancer studies. His areas of interest are fertility preservation in men prior to undergoing cancer therapy, Leydig stem cells in men with testicular failure secondary to cancer treatment. The importance of this preservation will be known only to those patients who underwent this. So much important. He has co-authored over 300 publications in the domain of male infertility and sexual dysfunction and sits on the editorial board of 10 journals. Most recently, he led the first study about sperm parameters before and after COVID-19 vaccination, becoming JAMA's most viewed study since its publication. A lot of we are discussing in India about the bladder dysfunction, sexual dysfunction, as well as these parameters. Let us listen a few words at the end of this surgical technique, what he concluded in this COVID-19 vaccination study, whether it's interesting, whether it affects the motility or number of the sperms like that. So with this, I hand over the program to Ranjit. Thank you once again, sir, for being with us today. Over to you, please.
Absolutely. Thanks, Chandramohan. Sorry, I can start the presentation.
Yes, please. Over to you.
Okay. All right. Very good. So let's share my screen.
Yeah, you are already co-host. You can. Thank you. We are able to see the screen very clearly and audible.
So let's start off with a case. Guy has azoospermia. He's 33. He's a healthy male, really no other medical problems. His wife is 31. She's healthy. She's been evaluated by a reproductive endocrinologist, and everything is okay with her workup. On physical exam, after multiple semen analyses showing 0 sperm, he's got about 4 cc testes bilaterally. And for those of you that have regularly examined testes, you know that these are pretty small testes with the average testis volume around 16 to 20 cc. On hormonal evaluation, we see that his FSH is very high, indicating that there could be likely a production defect. His testosterone levels, surprisingly, despite having very small testes, are actually in the normal range, and his LH is also normal. So the next step, one of the first things to do is a guy that comes into our clinics with azoospermia and no sperm, we want to diagnose to see if this is an issue with a production defect or an obstruction defect. Because the management of obstructive azoospermia and non-obstructive azoospermia are actually completely different from each other. So therefore, Craig Niederberger is credited with this very important work of showing how, just based on a physical exam and an FSH level, we're able to confidently distinguish between obstructive and non-obstructive azoospermia. And in men who have normal size testes and normal FSH, there's a high chance this could be obstructive azoospermia. But in our patient with a very high FSH and very small testes, I think we're pretty certain that this is azoospermia due to production defect. So high FSH, small testes, no need to do diagnostic biopsy, proceed and plan to think about therapeutic sperm retrieval techniques. So when you look at the histology of non-obstructive azoospermia, 3 different histologies can be seen. Sertoli-cell only, hypospermatogenesis on 2 extremes, and maturation arrest in the middle. And within maturation arrest, there's either early or late maturation arrest. Why is this important? If you do have a biopsy report in front of you and a urologist has done a biopsy or the patient has had a biopsy, they're usually going to bring the report with you, and you can sort of predict the chances of success with microdissection testicular sperm extraction based on what you see in the biopsy. But the important thing to understand is that even if the biopsy shows Sertoli-cell only syndrome, meaning there's absolutely no germ cells, there's only Sertoli cells on a simple open diagnostic biopsy, there's up to a 50% chance in which we can still find some sperm. And that's what I'd like to stress on everybody today, on how do we improve those chances of success with microdissection, Cassie. Which patient should we select? Which patient should we not select? Which patient should we offer a higher chance of success? And which patient should we offer a lower chance of success? And that's what we're really going to delve into today in the talk. One of the important things to understand is patients that often see us having undergone multiple biopsies, their chance of success is going to be lower. First, there's going to be a lot of sampling bias that these patients have undergone multiple biopsies. And 2, they'll have lots of scar tissue inside the testis if they have developed a lot of biopsies leading to scarring. It's a nice study that we published back with Dr. Schlegel showing that patients who've had 3 biopsies or more will have a lower chance of success with microdissection testicular sperm extraction. So unindicated diagnostic biopsies are likely not useful. If they're done for therapeutic intent, then maybe they will have some prognostic value. So finally, where are we with this case? This is a guy, they're a young couple, they have a very high FSH, they have very small testes. One of the first things that you want to think about before you take them to microdissection TESE is genetic testing, because this will absolutely change your management based on deletions identified on the Y chromosome. So who should be offered genetic testing? When you look at obstructive azoospermia, that's a separate section. We won't talk about that today. But in non-obstructive azoospermia, men who have severe production defects, very small testes, very low sperm counts, we should be thinking about doing a karyotype and a Y chromosome microdeletion, because there are genetic defects within the karyotype that can get passed on if we do find sperm, that we want to make sure that we rule out with pre-implantation genetic testing if that is indicated with the embryos. So when you do look at Y chromosome microdeletions, you could either have an AZF-A, AZF-B, or an AZF-C deletion. Important to note that if you do see an AZF-A or an AZF-B deletion, then the chance of success with microdissection TESE is almost 0%. So patients should not be offered micro-TESE. And after that, the options at that point are donor sperm, if it allows, in the religion and in the culture, or adoption. However, if you do see an AZF-C microdeletion, then there could be some rare foci of spermatogenesis inside the testis, and microdissection TESE can be offered. However, in up to 85% of people that you do genetic testing on in men with non-obstructive azoospermia, you're likely going to get something completely normal. So 15% chance you're going to find genetic defects, 85% chance you're going to find something normal. And it's often frustrating because patients don't know why they have this no sperm in their ejaculate. And often it's frustrating from a clinician standpoint, from a couple standpoint, when we truly can't give them any sort of an answer as to why. I think we all know in the back of our mind that there's some genetic defect that happens sometime along the way that either caused progressive loss of spermatogenesis or just no sperm to form, where there's some meiosis defects that led to maturation arrest, either at the early stage or the late stage. But it's really frustrating at this point because we truly don't have any clinically approved tests to identify routine genetic defects in men with azoospermia due to production defect. So now we're sitting with this couple, we're planning for surgical therapy. The genetics have come back completely normal. His testosterone's normal. So really minimal role for medical optimization. But surgical therapy, you could certainly offer all of these conventional surgical treatments for sperm retrieval, such as either fine needle aspiration, percutaneous biopsy, open biopsy, and multiple open biopsies. And I think it's certainly worth your time to discuss all of these treatments with the patients. But truly, we are here today because we want to talk about the one that offers the most success, which is microdissection testicular sperm extraction. And what is the principle of microdissection TESE? It's basically using a microscope to identify areas of spermatogenesis that's the most advanced histology within the testis. There will be tubules that we can identify the differences, and hopefully those areas of spermatogenesis will have mature sperm that we can use for assisted reproduction. Dr. Schlegel and I published this paper back in 2006, where we showed bivalving the testis, identifying small areas of spermatogenesis within the testis will have the best chances of finding sperm in men with non-obstructive azoospermia. And the goal really, and a lot of people ask me this question, Doc, do you know which tubules have sperm and which tubules don't? And I truly think we don't know the answer to that question, unless we're going to use advanced visualization techniques, more advanced imaging techniques. Right now, the technology does not permit us to identify which tubules have sperm and which tubules don't. However, the one thing that I think all of us should know about micro-TESE is we're looking for differences. If all the tubules look similar to each other, meaning they're all scarred, they're all atrophic, they're all flat, then the chances of micro-TESE working out in the patient is low. Similarly, on the other end of the spectrum, if all the tubules are big, they're full, they're opaque, which can happen in a lot of cases in early and late maturation arrest, then certainly those chances of success of those guys having sperm in their testis biopsies will also be low. So very important to know that with micro-TESE, all we're looking for is differences. We need to see differences from one tubule to the other in terms of size, in terms of opacity, in terms of whether it is larger or not. This is a short video basically demonstrating the principle of micro-TESE and how we do the surgery here at the University of Miami. very similar to how Dr. Schlegel described it back in 1999. Actually, you deliver the testis, and with an operating microscope, we're basically bivalving the testis with an ultra-sharp microknife. Usually, I do a holding stitch with about 5-O-proline, and very carefully with 2 mosquito forceps, you bivalve the testis, and with either jeweler's forceps or with bipolar forceps, which can be used for coagulation, you take out tubules that are larger. And usually this is a nice representation. It's rare that we actually see this in a lot of patients. Sometimes it's pure luck that we take some tubules out. We don't know where they are, and the embryologist says that's sperm. And sometimes the tubules are pretty obvious where they are big. But as a surgeon, I've also gotten into the habit of processing the tubules myself. I do not rely on the lab to process it. So we usually put about 10 tubules in Eppendorf tube with very little fluid, because you don't want all of the sperm floating in a lot of fluid. Pass it through a 24-gauge angiocat up and down after mincing it a lot with iris scissors, and basically give a drop or two to someone in the operating room that's assisting you with looking for sperm. And usually if we do find sperm, we're able to pretty easily stop the operation and So that's basically a description of patients who undergo microtesy for non-obstructive azoospermia. So I'm happy to take questions, concerns, and talk about the operation, who to do it in, who not to do it in, and what the follow-up is. So, Dr. Chandramohan, you're mute.
Sorry, but most of the times uh, we initially used to do open biopsy they used to call to the infertility center where embryologist is side by, and they will see and tell that okay, you can go. And then urologist in the beginning of the practice they do it. To be honest, I'm sharing my practical
Yeah,
experience. If you don't mind, the first surgery I after I All India Institute and Chandigarh training after I came to Hyderabad is testicular biopsy, where you need a small instruments. That time we used to press, cut, and then open. We had only one thing in mind, that if you use catgut, antibodies may form. After that, it is useless. This is the that time training 2004. I am telling. I used to think proline or catgut. That much is the only knowledge I had at that time. And slowly, as the conference is going on, we thought that biopsy can be done by needle aspiration, continuously keeping testis fixed position, take a bigger scalpel needle and put an aspiration, and then flush it with the whatever solution we have to give with it. Now, recently, as you said, opening the testis capsule and taking multiple beats in the lab along with the concerned person, so that you give the best whatever the patient requires. Ultimately, a good quality sperm, as many as possible for storage, is the aim, because you cannot open it again and again.
correct.
After that, they said that bilateral opening of the testes, bilateral multiple incisions, bilateral multiple biopsies, and take as many as if you don't open it again. So what do? You open horizontally one testis, and if you get a lot of good sperms, you'll stop it there, or you wanted to do something more.
No, I think it's so. First, I think you have to determine. So, testis biopsy, what you described, or epididymal aspiration, is very good for obstructive azoospermia.
Yes.
So, patients who have chlamydia, gonorrhea,
Yeah.
any STIs, injuries, trauma, CBAVD, congenital bilateral absence of the vas deferens. I think all of those simple open biopsy or using epididymal aspiration is excellent. 40% of patients with azoospermia will have obstructive azoospermia.
Yeah.
So 40% of the time, you'll get away with what you did in 2004. Nothing has changed there.
Yes.
In 2021, I guess, non-obstructive azoospermia has advanced. Patients who don't make as much sperm,
Yes.
patients with small testes, high FSH, it is those patients that need the microtesy. People
Yeah.
think that they need microtesy for all azoospermia. No.
No.
Only 60% of the time you actually need it. And in these small testes, yes, if you open up the first testis, you find large tubules, and by the time you're closing the testis, they've already found sperm. Absolutely, you 100% stop. There's no reason to go to the other side, because if the lab or the person who's looking at the sperm has found 1 or 2 sperm, that means there's way more sperm in the tube that you gave them. And so that should be sufficient, not just for that IVF cycle, but it's likely good for other future IVF cycles as well. However, if they don't find sperm by the time you've closed off with the proline, then usually I open the other side. And the patients know this, the chance of finding sperm, if you don't find it on one side, on the other side is only 10%. But 10% may make a difference between a biological child versus not, right? So, and so I think especially in couples from the Middle East, you told me that a lot of people from Asia are listening, where donor sperm is not even an option. Patients are willing to do anything to get their own sperm for even 5%, 3% chance. So I think if you're there, patients under anesthesia, the embryologist is there, you have to give them the best chance of finding their sperm so they can pass their genes on.
Yeah. So my second question is, if you have very small testes with TSA, sometimes FSH and LH are normal. Usually, don't think it is a theoretical combination. They do, and on an average, Indian testes are not very large, and if they
Right.
have normal and azoospermia, uh, usually what we do is a needle biopsy to confirm where are we now, like that is essential to proceed towards apart from transrectal ultrasound, to go towards the non-obstructive or obstructive, or directly go, is there any harm doing biopsy only for diagnostic purpose in the present era? That's what my straight question.
No, it's a very good question. So if you look at the guidelines and the correct statement now is, if you have normal FSH, so true FSH 3, 4, 5, and testis volume is not 4 cc, but like 10, 12 cc, 14 cc, Indian testis average size, okay, 12 cc, 14 cc. Doing a needle biopsy to confirm obstructive versus non-obstructive is not wrong. You should 100% do it.
Yes.
Because if you do find obstructive azoospermia, then you can send them for reconstruction if they cannot afford IVF.
Yeah.
Or propose, doing testis biopsy on the morning of IVF. Hey, I found sperm simple on a needle tessa. This is all we need to do on the morning of the, we don't need anesthesia. We don't need microscope. We can just do simple local anesthesia and get sperm.
Yeah.
If there is no sperm, then you have the diagnosis of non-obstructive azoospermia. Order the karyotype by chromosome microdeletion, see if there's any problems there, and then plan for anesthesia, microtessy bivalving on the day of IVF or before if they don't want to, do it along with the IVF. So no, absolutely. In men with normal FSH, normal testis size, according to country, I guess, totally okay to do needle tessa to confirm obstructive versus non-obstructive azoospermia.
And when you logically see epididymal surgery, any surgeon who has done epididymis, we used to do only epididymovasal so-called fistula, not side-to-side anastomosis, because we never had microscope. After that, I have given up. There's no point doing like that. I have never done it. And the epididymis, if you are doing aspiration or anything, it is a single tubule continuous, everybody knows. What are the chances of completely damaging? Is there any way you can do disastrous irrecoverable damage to the epididymis? You should know, because you will be in and out seeing the microanatomy. Something loosely doing epididymis left, right, like this. Now I am feeling that touching the testis. Honestly, I stopped biopsy also. I feel that if nobody refers, varicocele is also with lot of pressure and full bunch of varicocele is there, then only I am operating. So naturally the youngsters want to come into andrology. Now they want to. So even Mosin regularly says that, sir, something I am looking in andrology, my life is andrology, like that. What in the initial phases for general urologist, what we should not do with testis when evaluating in infertility? If you can
Very
tell
good
1 or 2
question.
points.
It's a very good question. No, it's a very good question. So the Motion, by the way, is the one who connected us, and he's been an avid follower. He's listened to every talk that I've given in the last. He's very dedicated. So kudos to him. Yes, very good. No, kudos to him. I'd love to meet him at some point. Yeah. The one thing that general urologists should not do is bivalve a testis like this and not know how to close the testis back. That is disaster. If you're doing an don't attempt PISA in everybody. People do PISA in patients with non-obstructive azoospermia. In 4 cc testis, you stick the epididymis in and out, you're going to damage the blood supply to the testis, and the testis is going to be atrophic, and there's not going to be any chance of any sperm in the future. So make sure you're those are all like severe damages that I have seen. And epididymis, you mentioned there's one tubule. Actually, in the head, there are 8 tubules. In the midpiece, there are, 11 tubules in the head, 8 in the midpiece, and 3 in the tail. So there's actually different number of tubules in the caput body and the tail of the epididymis. So when you're doing epididymal aspirations, if you have a microscope, usually just go to the head, poke one tubule, you'll get enough sperm. You don't need to poke a whole needle through the entire epididymis to try and get sperm. So even if you poke one in the head, where you will see viable sperm in patients with obstructive azoospermia, you don't need to do more than that. And the most important point that I want to underscore here is everybody thinks andrology is going to go away because IVF is taking this up. IVF is not 100% successful.
Yeah.
No, even in the best of the best centers in the United States that do the most number of cycles, in a 35-year-old female, the best chance of her walking home with a baby is 60%. And of course, if you do that in not as good IVF centers, not good female age, with female factor, male factor infertility, now you're talking
except 30% only in India.
Exactly, 30 to 40%. So the remaining 60 to 70%, they have to come back to us. And that's what's happening now, is people are going obstructive azoospermia. They got sperm, general urologists got sperm. They went to IVF, they spent $50,000. Now there's no more money in the bank. And now they want to conceive. They're like, doc, do whatever you can to let us conceive monthly. Because IVF cycle is one attempt. That's done, right? Whereas if you reconnect, I know you don't do vasoepididymal anastomosis anymore. But even if they get some sperm back in the ejaculate, 1 million sperm, 2 million sperm, every month they have a chance of conception, right? Every month. And that, I think, and that's what we're seeing now. And I cannot reconstruct back if they've gone to a general urologist and had no clue and stuck the needle through the entire epididymis.
This is what exactly I wanted to.
And that chance is also gone. Right now, you've truly made that couple's chance 0% of having natural conception.
Not fair. You should not do. It's a crime.
Yeah. So I think if you're doing it, just do one side. Leave at least one more side for the expert andrologist, to go reconstruct. So I think that message, I think, is very important.
Yeah, fantastic. So don't meddle with the epididymis loosely with multiple punctures. And you are telling an important point that the blood supply also can be cut off. And that's disastrous. Not only the
testicular atrophy.
Testicular atrophy.
And important to understand, testicular sperm success with IVF is similar to epididymal sperm success. So if you have an IVF lab, they're happy to take testicular sperm. So don't go be heroic and go poke the epididymis.
Yeah. That's a very, very important message we got. It's a knowledge, basically. And what is your opinion about the antisperm in your research? Because I've seen 300 papers is not a antisperm antibodies. See, most of my question will be primitive because I'm an endourologist.
No, it's okay. Listen, I think you're catering to the audience. This is the audience, and I'm very happy with you.
Ideally, this is the only subject. Definitely, I am at LKG level, so try to understand. So, if antisperm antibodies in the private practice, usually we used to do aggressively in the initial phase. We used to write FSH, LH, testosterone, antisperm antibodies. Slowly, that fourth one disappearing in my prescription pad. So, what is the current role of initial evaluation of male infertility with oligoasthenospermia and azoospermia both?
No, so I think the hormones are still there. FSH, LH, testosterone, estrogen, I think is still there.
Yes.
I think if you have azoospermia and you have small testes, I think getting karyotype Y chromosome microdeletion is important. Yes. And then I think you talked about examination of the varicocele and congenital bilateral absence of the vas deferens if it is there.
That's must.
I think that's basic evaluation. Antisperm antibodies have disappeared because the role is like really not there. The only time I get antisperm antibodies is if you do a good semen analysis. In the semen analysis, it'll say total motility 48%. And then in progressive motility, it'll say 10%, wherein all the sperm are just stuck and wiggling, but they're not moving anywhere. And those are the times that I will suspect antisperm antibody. Patients have remote history of infections, trauma, testicular trauma, chlamydia, gonorrhea, tuberculosis, filaria, any of those things. Anytime the blood testis barrier is gone, you'll have antisperm antibodies. And that is so rare. And so only when there is a difference between total motility versus progressive motility, you should get antisperm antibody. And the treatment for that is usually just prednisone, 5 milligram once a day for 6 weeks. And if the couple can afford intrauterine insemination, where they can just wash the sperm and put it with a catheter inside, where the sperm basically gets dispersed from the antibodies and can move freely from now on, they can just do insemination, which is fairly inexpensive even in the Indian side.
Very good. That's a fairly good answer. I really liked it. And the second question, again a little foolish question, but gives annoying problem to us is grade 3 varicocele. Worldwide, they say that subinguinal microscopic ligation is the best. Laparoscopy is the other one crazily practiced. In Campbell, we feel that subinguinal microscopic ligation. I have a 3 into X Coral G's made US made loop. I meticulously dissect. Probably one vein I may leave. All other veins I will cut it off at one level, layer by layer opening. Still, I love that surgery because something is visible to my eyes. I common problem in private practice. To be honest, we can't leave all these cases to others because I am also a good open surgeon. So I
Right.
take out the card and layer by layer and then cut it. Somehow post-operative reports after 6 months to 2 years, they will get again varicocele for grade 3, grade 2. This happens in only two conditions: post laparoscopic pyeloplasty and post varicocele repair. 90% of the times ultrasound will say against you.
Excellent. Very good. No, it's a very
Concept
no,
is the new vein has to develop and they have to decompress, temperature has to come down, and the sperm function has to improve.
correct.
50% who where sperm count is improved, they won't come back, they might have conceived also, but the rest of the 50% who come are really tough to manage. Please enlighten on this,
Sure.
even though
No,
we are
very good question.
debating a little bit.
No, it's totally okay. I was going to show the varicocele video, but we might as well just discuss this question. I think it's very important.
So you
So,
have videos more to show now.
no. We'll just talk about this. I think this is way more important than showing more videos. People can just watch the videos on YouTube. Let's talk about
Oh, okay,
these
okay,
things.
okay, okay, okay.
These are the things that don't get discussed on YouTube.
Yes, sir.
So first of all, varicocele success in improving sperm parameters is 2/3. 66% of patients will improve. 1/3 of the patients will not improve. I think that you have to tell all patients going
Yes,
through the surgery,
yes, yes,
right?
yes, yes.
We still do not know which factors predict improvement, which factors do not. We think large varicoceles, bilateral varicoceles, low FSH, or high FSH, small testis size, large testis size. We have no idea, right? We just published a paper recently. It'll come out soon with a nice nomogram on like if you input all of these numbers, age, grade varicocele, laterality, FSH level, testis size, it'll tell you the chance of improvement of varicoceles. So I think with that, we need to do. Not every patient is going to have 66% chance success,
Yes,
right?
yes.
Large grade 3 varicoceles, FSH 18, testis size 4 cc, he's not going to have as much
Not
improvement.
going to have sperms.
Unilateral left grade 3 varicocele, testis size 12 cc, severe oligospermia, he's going to have improvement, right? So I think that's the first question. First thing to tell patients is not everybody is going to improve. Second question, varicocele recurrence, just like how varicocele incidence and detection and diagnosis was based on physical exam, needs to be done on physical exam again. If you write clinical indication varicocele and send it to the ultrasonographer, they're going to find a varicocele. And importantly, if you ask the patient if they actually did Valsalva, did they do it in supine? Did they actually measure the vein diameter? They would have done nothing. They will just say left small varicocele found. And now you have this patient whose sperm parameters have not improved 3 to 6 months later, and a diagnosis of varicocele in the ultrasound report. He's very stressed. He's like, doctor didn't do a good job. My sperm count didn't improve, and my varicocele is still there.
Yes.
I think most of the time it's only because of these things. And you make him stand up, you'll say, listen, I don't see the varicocele anymore, right? Ultrasound detected varicoceles are notoriously wrong just because the ultrasonographer is just looking for something and you've given them the clue. They're like, here, look, if you write just scrotal ultrasound, no indication, male fertility, you won't get varicocele back. Whereas if you write rule out varicocele, you will get varicocele because that's what the ultrasonographer is looking for. So I think it's all of these small things. I think patients need to know there's a 5% chance of recurrence rate, even in the best of hands. And I think when you truly see recurrence, I've never seen recurrences that are like a grade 3 varicocele gone to like grade 1, like small recurrences. If it's a true clinical recurrence, the patient will tell you, you will be able to see it from miles away that there is a recurrence. There's none of this like, oh my gosh, there's small veins sticking out there. No. I've seen recurrences and they're very big And even a college student will tell you that that is a large varicocele. So I think you have to reassure the patients that ultrasound reports are notoriously wrong. Do not get ultrasounds on everybody, either before or after varicocele, if you have a nice clinical exam showing varicocele presence. And tell patients sperm parameters improve in the best of hands, even in 2/3 of the patients. And we still don't know who it improves and who does not.
Do you feel that still subinguinal microscopy is better than laparoscopy by all means?
100%.
100%.
100%. Yes. Yeah,
100.
100%. I think so. I think I think in pediatrics laparoscopy is still very good. The reason subinguinal varicocelectomy is good is because you can spare the artery. The goal, I think, where we talked about what andrologists should not do. I think taking, even if you leave 1 or 2 veins, I think is okay. Please spare the artery. But the artery is so small, and using a microdoppler, I think, will certainly help a lot. And I think we do have a varicocele video on YouTube. You can go and watch it. It's a 2-minute video. And so I think is way more important. Sparing the artery, sparing the lymphatics, trying to make sure testicular atrophy is not caused, trying to make sure hydrocele is not caused. All of those are way more important messages than trying to take off all the veins in the varicocele repair. Because once the artery is gone, the testis is, it's atrophic. So now it's dependent upon basal artery for the entire blood supply, and you'll see the sperm parameters go down. So yes, so don't just say, oh, it's varicocele, I can do it, I can put loops and stuff. Please use the Doppler. Please make sure the artery is spared before you can tie off all the veins.
Yes. So last couple of questions. The chemotherapy, when the patients are planning, for any malignancy, nowadays chemotherapy has come in big way. Majority neoadjuvant chemotherapy is there, and in youngsters also we are seeing different type of cancers. Apart from the testicular cancer I am talking about, how many days before you take these sperms, how do you store this, and is there any chance that after chemotherapy, after certain period of recovery, you can see the sperms again and they can take chance afterwards also? A brief comment.
Absolutely. No, absolutely. So I think it's best to do the fertility preservation before the chemotherapy starts. Ideally, 24 to 48 hours before you should do it. I know it's very difficult, but that's the best time to do it, because the chemotherapy, especially platinum-based agents, cyclophosphamide, cisplatin, busulfan, all of those agents will cause immediate DNA damage in the sperm. After chemotherapy, usually I wait for 2 years before they can either start trying if they've received platinum agents. All of this is just platinum agents. All of the other just topoisomerase inhibitor, like all the other things, it's okay to go ahead and try to conceive. But if you've received platinum DNA breaking agents, then you have to wait at least 2 years before you can start conceiving or get sperm again. There's a 10% chance of azoospermia after receiving platinum-based agents. So that's why this whole fertility preservation is done. 90% of the time it's fine, but usually you tell patients it's like an insurance policy. If you're fine, if you have sperm after chemotherapy, please, that's great, let's go ahead. If not, sperm that's stored before chemotherapy is good for 15 to 20 years. And so I think that's the message that you want to convey, especially kids who are not yet thinking about having children at all, and their parents are thinking about whether my child is going to be alive or not. Having this discussion with parent and the child is very difficult, but we should have it.
So the last question, you have done so much research on COVID vaccination, and now it's a hot topic of the world. This I divide into A and B. This is the last question. COVID as such impact on the sperm count and the fertility. I have seen last 6 months, majority of the people who are more than 40 years, particularly to 40 to 50 years, have difficulty in voiding. Very, very obvious after 2-3 months. Definitely our research scale is very low, but you have done it research and you have published in paper and it's most reviewed. Let us have some knowledge on that, because when you've done so much, what is your inference about the COVID vaccination? Even if you can comment on the COVID, because vaccination I don't want to talk more, but you have done it. These two I wanted to know, COVID and COVID vaccination on male infertility, erectile dysfunction. A brief comment.
Absolutely. So I think COVID virus itself can be present, and we've shown this in studies in the testis and in the penis long after the infection. How it's able to be dormant, how we're able to find this in the testis. I think in the testis we published 3 months after infection. In the penis, during a penile implant surgery, 7 to 8 months after infection, the virus is still present in the penis. in the endothelial cells inside the penis. And so I think there is a true association between COVID causing male fertility issues, COVID causing erectile dysfunction. And we're actually having a recent paper showing COVID is present in the prostate in a guy that underwent TURP 4 months after that the COVID is still present there. So how it's able to evade the immune system when the PCR is negative, what it's doing in these organs, especially in male urogenital organs for all these months, don't know. We're still doing research. Hopefully next year we'll have some answers for these. And thankfully the fertility issue, we found that it's only down for 3 to 6 months. In 6 months, it seems the sperm parameters seem to improve. So if patients who get COVID trying to conceive right now, tell them to wait 3 to 6 months before they start again, because the sperm parameters seem to recover in 6 months as long as the infection was not that bad. And then the last point, we did publish the study that COVID vaccine was safe. People were concerned thinking COVID causing fertility issues, COVID vaccine will do the same thing. But that was the biggest concern. So then we did the vaccine study and we found that there was absolutely no difference in sperm concentration or sperm motility. So important message there, COVID is bad. Try not to get COVID if you're trying to preserve your sex life and your fertility life. And vaccine is one way to prevent COVID. And so get the vaccine because it's safe.
Fantastic. Swami, you like to ask any questions or we conclude? Swami, unmute.
You're mute.
Unmute, Swami.
He's trying his best, but no, this was a very good discussion, Chandramohan. This was awesome.
Thank you very much, Ranjith Ramaswamy. I really appreciate the vibrance I can see. You're too young. I just wanted to know because I compared everything with my MBBS life. I did in 1991 to 97. Half of my batch is in US. I am from Usmania Medical College, and half of
Right.
my batch they have written USMLE. I have forgotten your medical school is there. That question is wrong, but you are really vibrant. My God, you should meet us in India. If you come to any urology society of India, any conference in future, maybe we also become secretaries. We also become this thing. We love to call you,
Sure.
and you should give a good talk on plenary session. Having 300 papers on this is not at all a small thing. Great, highly
Perfect.
appreciated. You achieved it at a very younger age. I wish you all the best. You will become future in the guidelines of the andrology. You should be there from the American Urological Guidelines. Thank you very much being with us. I thank once again Mohsin for introducing you. Great
Absolutely.
opportunity. Great opportunity to interact. I will
Thank
be
you.
in
Thank
touch
you
with
very
you.
much.
Thank you very much.
Absolutely. Bye bye now.